Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Hello, this is Dr. Jason Taxi from Maryland Oncology Hematology. Welcome to another episode of Oncology Radio. Today I have the honor of speaking with Dr. Jikai Zhu from Anne Arundel Urology. Our topic today is going to be recurrent and advanced prostate cancer. Welcome, Dr. Zhu. Could you tell us a little bit about yourself?
Thank you, Jason. My name is Jikai Zhu. I am a urologist in the Maryland area, and I am with Anne Arundel Urology for the past 8 years. And I am the director of our Advanced Prostate Cancer Clinic, and been working with advanced prostate cancer patients for the past 7-8 years, and been working with Dr. Jason Taxi closely regarding treatment of these patients. And it's an honor to be here to talk with you today, Jason.
Thank you and welcome. So Dr. Zhu, how do you follow patients with prostate cancer after they've had definitive treatment with either surgery or radiation?
At that point, if they are two points above their nadir or have 3 consecutive PSA rises, we will do imaging to see if there's any metastatic disease.
What's your preferred imaging? I know I often tend to do CT and bone scan, but there's a lot of types of scans out there, I think, that people have heard about, such as PET scans. Do you have a preferred approach when you see the PSA?
Yes. Yeah, that's a good question because CT and bone scan is our preferred imaging as well. It's the one we use most often. It's also the least expensive. The two PET scans that we use are sodium fluoride PET or the Axumin PET scan. They tend to be a little bit more sensitive, and however, we do run into some insurance reimbursement issues in those cases. But it is more sensitive, so you have to basically weigh the benefit for doing those studies in certain patient populations. If I'm very suspicious in someone who's fairly young and I want to detect detect any small lesions, I will probably prefer the PET.
Got it. Yeah. It's interesting, all the new technologies, and there's even a type of scan called a PSMA PET coming out, and it'll be interesting to see where the field goes in terms of imaging as these new techniques become approved.
Oh, go ahead. I think have you seen that being available outside of clinical trial yet?
I haven't. Not yet. I mean, I keep hearing about the PSMA PET becoming available, but so far, other than clinical trial, I've not been able to see anyone get it. But I think that scan is very interesting because some of the early data suggests that it could really change what we do with these early PSA rises, because it's far more sensitive in showing us visibly where the cancer might be in a setting where the more conventional scans like CT and bone scan aren't able to visualize anything. So I anxiously await approval of that test.
Agreed, definitely.
So going back, to PSA rises, and I know my interest as a medical oncologist is always the medications that we use with recurrences. I don't know if you have any comments about some local therapies that we may consider with a low PSA rise. We sometimes at our tumor board meetings, even talk about cryotherapy in patients who've had radiation. I don't know if you can maybe give a brief comment about your thoughts on that.
Sure. Yeah. So it depends on, as you know, it depends on their primary treatment. So if they had surgery as their primary treatment, they do have the option of radiation, as salvage radiation if they have biochemical recurrence and assumed localized recurrence. If they had radiation radiation as their primary treatment, then their options would be what you just alluded to, the cryotherapy versus hormone therapy. And there is also the option of active surveillance or observation, depending on their PSA doubling time, meaning how quickly their PSA is doubling the original value, and their risk factors. So it's somewhat of a balance between maintaining their quality of life, avoiding some of the secondary side effects from additional treatment, and sometimes not over-treating some fairly indolent cancers, perhaps. So it is a balance when we come to these situations when someone had biochemical recurrence.
Yeah, I definitely worry about sometimes the risk of over-treatment. So I agree. We think we all use the PSA doubling time as a good guide, to help us know, when or even if we should treat patients. Do you have certain cutoffs with the PSA doubling time that maybe you use to to strategize or to maybe separate patients into risk groups?
Sure. Yeah. So it depends on. First thing I look at is their primary pathology. Were they Gleason 6 or low volume Gleason 7? If they had any prior, there's some genetic testings, Oncotype DX, that's available that stratifies how high risk or low risk their cancer is based on DNA testing. After reviewing their pathology, I look at their PSA doubling time, and if they have a PSA doubling time of less than 3 months, that's certainly a red flag. They're at high risk. The gray area is between about 6 months to 9 months or so. And I think previous data showed if they have anything greater than 9 to 12 months, they have a high probability of long-term metastatic free survival and overall survival. So the gray area really is between the 3 and 9 months period for PSA doubling time. But if they had high risk pathology to begin with, Gleason 8, Gleason 9, then I am much more apt to start treatment than if they have lower risk disease. And both of those factors, PSA doubling time, their pathology, play a significant role when you make that decision.
Yeah, there's some data that I've seen with the less than 3 month doubling times where median survivals are similar to patients who have visible metastatic disease. So I definitely agree that that's a pretty easy cutoff to look at in terms of knowing to start treatment. So let's say that we're reaching a point with a patient where based upon pathology and PSA doubling time and they're in biochemical recurrence with no visible disease that we've decided to treat. What is your preferred first line of therapy? How are you initially treating these patients?
Right. So if we decided to treat, do you mean, sorry, Jason, do you mean if they had surgery or radiation in the past?
Oh yeah, I'm sorry. Let's use an example of a patient who they've had definitive therapy. They are not a candidate for more local therapy, and the PSA has reached a level where we feel maybe it's time to start to bring it down. But they are in biochemical recurrence, so there's nothing visible. So we're at a point where we're thinking about systemic therapy now. Yeah, gotcha. Sorry. So the systemic therapy, what you're discussing is androgen deprivation therapy. As we all know that
prostate cancer is sensitive to testosterone. And we figured this out probably 4 decades ago. And with deprivation of testosterone levels, we can prevent these cells from progressing and sometimes even shrinkage. So in the past, when we didn't have systemic therapies through medications, bilateral orchiectomies was the initial treatment option. But currently, because of technology, we have different treatment options to suppress the testosterone levels. And these are known as the gonadotropin releasing hormones. And there are 2 types. There's one that's an agonist, and then there's another one that's an antagonist. Basically, what they both function to block the testosterone production. And currently, for biochemical recurrence for these patients without meds, our goal is to start them on these treatments on an intermittent basis because the data show intermittent hormone therapy is equally beneficial in overall survival as continuous hormone therapy. I don't know if we may want to go into some of the side effects of hormone therapy, and that's why we do intermittent.
Sure.
But systemic hormone therapy definitely is the treatment of choice in these situations to lower their PSA values and perhaps decrease their chance of metastatic disease.
And so I think that's a good segue into side effects because, when we suppress testosterone, there are definitely, negative consequences, which is why we like to limit, the use of these agents as much as possible. What do you think is the biggest challenge in terms of side effects, or perhaps I should ask, what are the side effects that you're concerned about when you're treating these patients?
Yeah, so the biggest thing is our patient population, right? Most of our patient population in this group is in their 60s and 70s and 80s, and we also see some 90-year-olds. Their metabolism is already slower. And by starting these treatments, we really increase their risk of metabolic syndrome if they don't have it already. If they do have it, then we can worsen their diabetes, hypertension, heart disease. In addition, a lot of the patients who start hormone therapy become fatigued, so they're less active. And the long-term side effect from hormone therapy can even decrease their bone density. Since these patients are already elderly, they're at even increased risk with decreased bone density and fractures. Taking all that together is my biggest concern is I don't want to start hormone therapy on someone and it will impact their quality of life. If starting the treatment will decrease their activity level, decrease their ability to enjoy life, then it becomes much more challenging. So a lot of times we have a fairly lengthy discussion with patients regarding these side effects before we start them. And in this stage, in the biochemical recurrence stage, it really is a risk and benefit discussion with these patients. It's a little easier when they're high risk. But when they're low risk patients, it's somewhat more difficult to say that they doesn't necessarily need hormone therapy right away. And that's where the monitoring, the active surveillance comes in.
Yeah, it's interesting, in that I think as physicians, or at least I sometimes feel compelled to want to intervene, but sometimes that's not the right answer, especially when you take a diagnosis like prostate cancer, where patients can survive even in the recurrent setting for many years, and even many patients can live the normal life expectancy. So it's, as a physician, I think sometimes a challenge to know when not to treat, and I think biochemical recurrence is one of those settings where it does take some nuance to make those decisions. when we look at side effects of low testosterone, I know I personally find that the biggest one patients often mention to me is the hot flashes, because that has the most immediate quality of life impact that they're noticing on a day-to-day basis. You
Right.
mentioned,
Yeah. Thank you for bringing that up. Yeah.
um,
Yeah.
you mentioned bone health, which I think, even though it's something that's not always symptomatically noticeable, may in fact have the biggest negative consequence over the long term as somewhat of a more silent side effect. So I know that we often talk about doing bone density scans in patients that we're going to treat to keep an eye on bone density. In somebody who you are concerned about bone density, what are things that you recommend to them to help maintain or improve their bone density on treatment?
So yeah, sorry, Jason. I thank you for bringing up the hot flashes. I forgot to mention that. It is, I totally agree. It is one of the bigger side effects that people notice right away. And I find most patients tolerate it well. I don't know if you have any strategies in decreasing their hot flashes, but most of them that do find it tolerable, and over time it's not too bothersome to them.
Yeah, I find time is the answer to that, actually.
Go ahead.
I'm sorry. Yeah, I said I find that time is often the answer to that, because I've had a hard time identifying a medication that really effectively diminishes the hot flashes in everybody. But I do find that
I agree.
In patients on treatment for longer, they tend to get used to it and notice it less. So I often find it's a matter of giving it some time.
I agree. Yeah. To your original question about the bone density, we use the DEXA scans, and the DEXA scans we obtain, we look at their age-adjusted T-scores, and then if they have osteopenia or osteoporosis or normal DEXA. And then we also calculate a FRAX score. A FRAX score, as you know, is taking their lifestyle and their other risk factors into account, and calculating their risk of having potential major hip fractures or other fractures over the next 10 years. And using these objective findings, we decide what treatment, if any, they should be on. We do recommend anybody on hormone therapy to be on calcium and vitamin D supplements to maintain a good bone density and health. And we also recommend they keep up their activity levels and manage a healthy diet. But if their DEXA showed increased risk, either of FRAX score or diagnosing of osteoporosis, there are some oral agents that's available, along with injections and IV infusions. The oral agents can help. There are bisphosphonates that can help with rebuilding the bone. And the injections such as Prolia or Xgeva can also help in preventing fractures. And then the infusions that you're pretty familiar with Zometa, can help with preventing future fractures as well.
And I often, myself have, really like Prolia, only because in the form you mentioned, Xgeva, we're able to then adapt and use it in the setting where patients later develop visible disease. So it seems like a good one just to transition for later use with good tolerance. But there's certainly lots of options, and sometimes the hard part is narrowing down the options. But I think some of the injections like Prolia tend to be a good approach.
Yeah, Prolia is definitely a great option for someone who doesn't want to take a weekly medication, and since it's every 6 months. And the only challenge I have there, I don't know if you have had any, is just the reimbursement and coverage in certain insurance products.
Yeah. It's certainly harder for those who their DEXA scans don't quite show osteoporosis. So that is insurance coverage in any setting that we treat, I think, is often an issue that we have to navigate. So I would agree. Well, kind of, jumping back, so, we've talked about, men who have biochemical recurrence, and that, often they reach a point where we want to bring the PSA down. And we've talked about giving intermittent treatment or taking a start and stop approach with the GnRH agonists. And often, we're able to manage patients like this for many years, which I think is one of the exciting things in prostate cancer is people often, even in high-risk settings, do extremely well. We do, unfortunately, even with this intermittent approach, reach a point where these agents stop working. And we've had, I think, recent excitement with the approval of 3 new drugs or newish drugs, I guess, because they're not brand new anymore, that are able to enhance the benefit of the GnRH agonists. The drugs apalutamide, enzalutamide, and darolutamide. How have you been using these agents, or how have you been adapting this to your treatment regimen?
Yeah, sure. So of the 3 drugs that you mentioned, the first drug that was approved for this stage, which is the castrate-resistant stage, without any signs of metastatic disease, is apalutamide, and the apalutamide trials showed, great. The apalutamide trial showed definitely improvement in survival over control group when these patients are given the drug at this stage. And about 6 months later, I believe, that's when darolutamide came into the scene. And then the enzalutamide came soon after that. And with all those 3 drugs, they have fairly similar median metastatic-free survival benefit. I think, correct me if I'm wrong, I believe the apalutamide and the darolutamide both showed about a 22 to 24 months median metastatic-free survival. And then from the Spartan and Aramis trials, and then the Prosper trial was for the enzalutamide, and that had also similar metastatic-free survival benefit. And then I think for the overall survival, it had about a 27% reduction in risk of death, and a median overall survival of 67 months. So I think all 3 drugs are fairly equivalent in their overall benefit for these patients. The difference in these drugs is their side effect profile and how patients tolerate them. Erleada or apalutamide has a significant skin rash side effect that affects about 25% of the population that takes it. But darolutamide has somewhat less, and in addition, darolutamide has less neurological side effect. I think in the trial, and I think in previous experiments, they found that it didn't cross. I don't think barely any crossed over to the blood-brain barrier. So assuming it has very low neurological side effect, which helps in patients who probably are elderly, and decreasing any type of neurological interaction may be beneficial in these patients. Given that their benefit is very similar for all 3 drugs, it really comes down to managing their side effects and a discussion with the patient regarding the different options. I don't know if you do anything different in your practice, but I think our approach is, in these cases, is a fairly open discussion with the patients.
Yeah, I would admit that I think when we first started to see this data, I tended to favor enzalutamide because I had already had familiarity with it from the metastatic setting. So it was, for me, it was an easy transition. But I think, we've all seen, what my biggest concern with some of these drugs in terms of side effect management has been the central nervous system side effects with, enzalutamide in particular and apalutamide. So, All things being equal, I tend to like the idea of darolutamide, but that tends to be the one that I've personally had a harder time with insurance coverage, lately. But I don't think we know that from an efficacy perspective that one is better than the other. So I agree. I think a lot of it becomes a conversation with the patients of the three drugs, to compare some of the side effects you mentioned, and then navigate getting approval. But I think these are all exciting. I mean, this is
Oh, definitely. Yeah.
Data showing improved survival in a setting where we really didn't necessarily have a standard of care before. So the advances that I think we're seeing in prostate cancer, are really exciting and and great to watch.
It's quite amazing, Jason. Remember, just going back to 2018 when we didn't have any of these options, right?
Yeah.
We had zero options for this stage, and just within a year and a half, all of a sudden we had three separate options for this stage. It's a big impact on managing these patients.
Yeah, I mean, and it's great to see these improvements. I mean, I think this patient population is benefiting greatly from what really are rapid advances. So it's exciting to be part of the field right now and get to see the results of these trials and even sometimes participate in the trials. So definitely look forward to more things coming soon. Maybe just to kind of move on a little bit further. So we've talked about biochemical recurrence and just the different pathways we follow with initial intermittent therapy, with testosterone suppression, with perhaps the later addition of these three newer drugs. Unfortunately, many men over time will develop visible disease, or in some cases, they have visible metastatic disease at diagnosis and are not candidates for some of the local therapies we talked about. What would you say are the locations that we tend to see visible disease show up in these patients? What do you see as the most common places?
Yeah, I think, the most common places we see is localized lymphadenopathy and then retroperitoneal anopathy. And the other common places are basically the skeletal mets into the spine or pelvis. Those are probably I will say, almost the 80-90% of patients that initially start with metastatic disease tend to have mets in those locations.
Yeah. I think every other location is certainly far less common, but I'd agree. Those are the places that I tend to see.
So anything else, anywhere else makes me very suspicious. Their disease is very high risk.
Right.
I don't know if you agree with that. But any other location, it definitely makes me really concerned for them.
Yeah, I would agree. Though I will say it's interesting. I've seen a small percentage of patients who at diagnosis have lung involvement, which is quite uncommon, and there's a cohort of them that do better than predicted, and I don't know that I fully understand why, but that may be an exception to that.
Interesting.
So we've talked about intermittent therapy with biochemical recurrence to try to minimize side effects. What are your thoughts on intermittent therapy with the GnRH agonists and when people really have visible disease? Is that something that you use, or do you tend to use therapy more continuously?
Yeah, that's a good question. It's somewhat controversial, and just from personal experience, I have had other providers taken patients off hormone therapy when they had metastatic disease, and I have seen them not do very well. So my practice, I tend to, once they exhibit metastatic disease, I tend to keep them on baseline hormone deprivation for the long run. And I do tell the patients that, this is most likely a lifelong event treatment that they are going to stay on it when they have metastatic disease. I think when they have metastatic disease, even though our imaging is able to detect these radiographic disease, but there's, that there is microscopic disease elsewhere. And I'm very concerned that by taking them off, I'm allowing these other non-detectable microscopic disease to progress. And if I can keep their disease, at as low volume as possible, without, of course, we have to balance their quality of life and their goals as well. But if their main goal is to suppress the cancer, then I will keep them on it for the remainder.
Yeah, I would agree. I mean, I worry about, like patients who have bone involvement when we take breaks, I worry about the risk of them presenting with pain or even in some cases, the risk of fracture. So I would agree. I think there's always exceptions, of course, but I think once there's visible disease, I tend to keep patients on it continuously, to prevent those potential risks. So besides testosterone suppression, what would you say is your go-to frontline approach for patients when they present with visible disease?
Yeah, so if they are hormone sensitive still, meaning that their cancer presented, in a biochemical recurrent stage, and let's say they received hormones intermittently, and then they progressed, and they're still sensitive to hormones, then I will keep them on hormones. If they're low volume, we can talk about potential treatments such as radiation to the oligomet, or localized treatments with radiation, along with adding abiraterone to their treatment regimen per the Stampede trial that came out a few years ago, which shows some benefit by adding this oral agent called abiraterone or Zytiga along with prednisone for this patient population. If they presented with de novo, no prior treatment, with high volume metastatic disease, defined as having or 3 or 4 or more bone mets or visceral mets, or what we mentioned earlier, mets outside of the spinal or pelvis region, then I think, we talked about this many times, I think those patients sometimes can benefit from initial treatment of chemotherapy agents based on some of the trials that showed great improvement in survival, and with Taxotere, right?
Yeah.
So those are the patients that, that we refer to you to get chemotherapy agents. There's a couple other agents that we can use, such as the enzalutamide, which you mentioned earlier, that we can use, and then apalutamide also we can use at this stage as well. I think there's a Titan trial showed that Erlita can also be used, which is apalutamide, which can also be used at this stage.
Yeah, there's definitely, just like in biochemical recurrence, I think this setting, to me has become really an exciting setting because there's really been a paradigm shift in how we treat. I think when you and I first started in our careers, I think the standard in the setting was really just suppress testosterone and not do anything else until perhaps the PSA went up again or the scans got worse. But I think it's become clear to me that the standard has changed now to where it's an LHRH agonist plus something else, and it's no longer just an LHRH agonist alone. And that's been, I think, a change over the last few years that has really, I think, led to much better outcomes for our patients. I think that the biggest challenge that we face right now is that, with the 4 options we have in the frontline setting, the enzalutamide and apalutamide, as you mentioned, abiraterone or chemotherapy with docetaxel, I don't think that we actually know if one approach is better than the other. So it becomes a matter of having to pick between four really good options, but not a bad problem to have lots of good options for these patients.
Right. Right. Absolutely. Yeah. It's the algorithm. We have a general algorithm, right? In treating these patients, but in each of these separate stages, we have many options that don't really separate themselves in regards to efficacy, because all the trials showed very similar efficacies in all these drugs, right?
Absolutely.
And it really, So it is a lot of it is based on your conversation with the patient and their comorbidities and the side effects from these drugs, and that combination is how we make our decisions.
Yeah, absolutely. I think the first data to come out was the data with chemotherapy with docetaxel.
Right.
So I think we very early after that data came out started to use docetaxel in this setting, but I think the community as a whole, the oncology community as a whole, has shifted towards using these additional drugs like abiraterone, enzalutamide, and apalutamide, just because tolerability, I think, tends to be no better than chemotherapy. I mean, I think it's a hard sell for patients to convince them to do chemotherapy when we have better tolerated options that probably work just as well, or sometimes even better.
Right.
You mentioned before.
On the flip side,
Oh, go ahead.
On the flip side, Jason, is sometimes when I present these data to the patients, some of the younger patients with high volume disease, I feel they could benefit from chemotherapy up front because one is, it's 6 cycles instead of some of these oral agents is somewhat indefinite long term. And they can tolerate that 6-cycle chemo. And then if they have any progression, you can put them on these oral agents as a subsequent treatment option. And I feel in certain cases, it's more clear to give chemo up front because of the tolerability of these healthier patients. And perhaps they don't want long-term side effect from these oral agents and more short-term, maybe perhaps harsher side effect, but at least it's a shorter-term chemotherapy agents instead. So it is, like you said, is a case-by-case when we treat these patients.
Yeah, I mean, I often, when I present it to patients, it's because I think, as you said earlier, that the survival data is pretty similar. I mean, in terms of how well these agents work, I mean, we would assume they have a very similar benefit, even if they haven't been compared head to head. So I often present it, such as abiraterone, which is, essentially often given as five daily pills if you include taking it with prednisone, versus chemotherapy. Sometimes the decision between being on a therapy over the long term, because I think with abiraterone, the median failure-free survival was around 44 months. So patients can be on it for quite a long time. So it's almost a decision between a long-term therapy versus more side effects with chemotherapy, but it being a more short-term therapy, because with 6 cycles, that's essentially getting treated over about 18 weeks. And so a lot of times the patients decide what they're more comfortable with. And then, we talked about some of, the trying to protect bone density early on. But now we're in a setting, talking about a setting where patients may have visible bone involvement. So how do you change your strategy now in terms of treatments to protect the bones from harm? I know we talked about Prolia before, but what do you do in the metastatic setting different?
Yeah, I think I mentioned the drug already, but Xgeva, which is very similar to Prolia, but given on a monthly dose, is our drug of choice for when they have metastatic high burden metastatic bone disease. In addition, they are also have the option of getting Zometa infusions.
Do you have side effect concerns with Xgeva?
Oh, absolutely. Yeah. With any of the oral or with the oral bisphosphonates and Prolia and Extiva, the biggest side effect that we talk about with patients is they have a higher risk of having a very nasty infection or what we call osteonecrosis of the jaw, especially if they undergo any dental work. So with these patients, I usually bring that point up and make sure they don't need any immediate dental work. And if they do, we'll have them do those first and then clear it with the dentist and then proceed with the injections after that. You also have to monitor some blood work as well, such as low calcium levels, but the osteonecrosis of the jaw is the biggest side effect concern.
Yeah. And certainly I know in my own clinic, I've had to stop these agents if we see any jaw pain or bone changes.
Yeah.
So, one of the messages I think I'm hoping our listeners are getting is how much treatment there is out there for prostate cancer and how well patients can do. It's probably beyond the scope of this talk to give every line of therapy. There's just probably not enough time. There are a couple of interesting drugs out there that I thought maybe we could comment on. I think it's always out there.
Sure.
In the press about immune therapies, and we're all really excited about immune therapies and oncology management. And there's one immune therapy, as you know, in prostate cancer that's been approved called Provenge or Sipuleucel T. So I'm just curious how you may have applied that into your own practice for prostate cancer patients.
Yeah, so that's a great question. Immune therapy is the exciting field in any cancer treatment. And interestingly, Sipuleucel T was, I believe, was the first immunotherapy that was ever approved to treat cancer, and that was back in 2010. And so Sipuleucel T is given IV infusions over either a 6-week period or a 3-week period, depending on their IV access. And the data from 2010 was, I think it was the IMPACT trial that showed about a 22% relative reduction in death and about a 4-month improvement in median survival. So it wasn't as impressive as people thought it was, but until you look at the post hoc analysis where they looked at patients in that subgroup had PSA less than 22, and their median overall survival significantly increased compared to the placebo group of up to 13 months. And I think that was also true once they started looking at prospective data in the Prostate registry, and they found patients with lower PSAs did better. And the lower the PSA in the lowest group, which is less than 5.3, did the best of all the patients. So I think the key here, and you're alluding to that, is when do we give it? And the key here is to give the best benefit, the most benefit you're going to get out of this therapy is to give it early. And so once you detect, and it is currently approved for that stage when you have early metastatic disease and they're castration resistant, meaning they're no longer responding to traditional androgen deprivation therapy alone. And there is a small window where if their PSA is low enough, they will get the best benefit, greatest benefit from this drug. And that's where I and you to give these agents in this early stage. And it's evident because, as you know, they are also studying this drug in active surveillance patients and patients who have non-metastatic disease. So it definitely alludes to that the earlier we give this drug, the better these patients will do. And so in my practice, I definitely try to fit this in as early as possible.
I remember when it first came out, and I don't think it initially had a lot of as much use as the survival benefit would suggest it should have.
Yeah.
I think
Yep.
it was. I think at that point in time, I don't think the oncology community necessarily understood immune therapies as well because often with Provenge we don't see the PSA fall, and we don't see the scans look
Right.
better. And I think back then we didn't have some of the newer immune therapies that we all see advertised in TV commercials like Keytruda. I think we didn't understand this entity of pseudoprogression, where with immune therapies things can look worse before they look better. And so I think it took a while for many of us to necessarily believe we should use it. And I think lately I'm personally trying to use it more than I had before because we're more used to what to expect with these immune therapies. And so I definitely have been, as you do as well, I've been trying to use it early in the disease course for that benefit.
Right.
And then the other interesting drug that you'll probably guess I'm going to ask you about is Xofigo. So this is really a bone targeted therapy that, since prostate cancer commonly can be found in bone only when it spreads. So this is something that I think we've all been using for a while to treat metastatic patients. I don't know if you can maybe just make a couple comments about this really interesting compound.
Yeah, so Xofigo is different than any of the other agents that we use. So Xofigo is radium-223. It's actually an alpha emitter agent that targets specifically the bone and the metastatic disease in the bone. And the patients that benefit, not only does it have a overall survival benefit, approximately about 4 months, but the patients that benefit from this are patients who have symptoms from their bone mets. So by giving this agent for these patients with symptomatic bone disease, you improve their bone pain symptoms. In addition, there is a benefit of overall survival and also benefit of delaying any type of skeletal events. So it's a very interesting agent, and it's very well tolerated, as you know. People have fairly minimal side effect from this agent. So I'm very excited about using these agents in this population, and given the lack of side effects and the benefits that they get from it.
Yeah, I really do like using Xofigo in patients who have had many other lines of therapy, but thankfully still only have bone involvement in other sites, who may just not be feeling well enough for other treatments, but we're looking for an option that can help manage the disease. And I found that it's one of the agents that is tolerated by most patients, with very few exceptions. So I definitely found that this has been a really good addition to our arsenal of treatments. Right now, I think as you may have said, we're giving 6 monthly doses, and I'm curious if there'll be a time where we're actually able to reuse it later, and give more than 6 doses, because I'm not sure that mechanistically there's anything about it that it shouldn't work, in a second course.
Right. Yeah, I think we definitely talked about that in the past. So, there shouldn't be any tolerance that's built up for it, right? It doesn't work that way.
Right.
It would be interesting to see if we can use it in patients who tolerate it well and is showing benefit from it.
And then even in a non-prostate cancer setting, because there are other cancers that can primarily involve the bone.
Yeah.
I would imagine over time that we'll see data in those settings as well. Well, I think that was we got through quite a bit, and there's always more that we can talk about. But I think that was really the list that I was thinking we might cover. Is there any other comments you have? Maybe I would ask, what are you most excited about for the future of prostate cancer management? Is there, in terms of where we're going for next steps?
Oh, sure. Yeah, I No, I think that was a lot that we covered in the past 45 minutes or so. But there's a couple. I think the future is that I'm most excited about is gene targeted therapies, and we're seeing that with the two new drugs that are coming out. That's already out. What I'm alluding to as Lynparza and the Rubraca, which are
Right.
PARP inhibitors and targeting gene mutations that we can test in patients. And I think that's the most exciting part about, I think the next couple of years. In addition, I think I'm excited about some of the other trials that's going on regarding Keytruda immunotherapy agents, and also the combination therapies with using some of these drugs in combination for some patients. And there's a lot going on actually, but they're all very exciting. And I think there's going to be, it's an interesting field because the dynamic and change is fairly rapid in medicine right now.
Yeah, it in a good way, it takes a lot of effort to keep up because the changes I feel like are almost on a daily basis. But I think all of our patients are benefiting from these rapid advances.
Absolutely.
I really wanted to thank you for your time today. It's been great talking with you as always, and hearing your perspectives on what I find to be a very interesting field. How would patients reach you if they wanted to touch base with your office? What's the best way to get a hold of your office or to schedule times to come meet with you?
Oh yeah, aaurology.com.
Great. Well, like I said, I really appreciate your time. It's always great talking with you, and I look forward to more discussions.
Absolutely, it's always insightful to talk with you, Jason, and it was a pleasure. Thank you.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.